Keaton Fletcher, an assistant professor of industrial organizational psychology at Colorado State University.
And I'm Mariana Arvon, an organizational psychologist who specializes in organization and talent development.
And this is Healthy Work. Welcome back to another episode of Healthy Work. I am so excited to be joined today by a repeat guest, one of our first repeat guests that isn't just a close coworker or partner of mine. So I will get out of the way and let you reintroduce yourself.
Yeah, hi, my name is Beth Stelson. I'm an assistant professor at Washington University in St. Louis, our new school of public health. And, some of the things that I research are trying to think about how we improve working conditions for healthcare and social service providers, not only to improve their health and well-being, but then demonstrate how by doing so and investing in our workers also improves patient and community health too.
And I am just so excited to have you back with us today to talk about some of your recent research on vicarious trauma, which is not something that we talk about a lot in IO psychology for sure, but I know that it's gained some traction in other areas and has certainly bled over into our field. And I think it's just such an important topic. So if you could just explain to me, what is vicarious trauma?
Oh, yeah, absolutely. So vicarious trauma is the trauma that workers have experienced indirectly when they're working with people or communities who've experienced trauma directly. So when we're thinking about it, the workers haven't experienced the trauma firsthand, though theoretically they could have experienced that in their own personal lives. But it's mostly because they are exposed to it indirectly because they're working with people who have experienced trauma. They also can be affected through the activation of psychological and physiological stress response pathways. And so this could be through a specific event. For example, if you're a nurse and you are talking with a patient who's experienced a form of trauma, but it can also be cumulative over time. When I think about vicarious trauma, I often kind of think back to the idea around smoking. I think that can serve as a helpful analogy to wrapping our heads around it. So when somebody's smoking, when they're lighting up a cigarette, right, that person is directly inhaling the toxins. That's directly affecting them. That's kind of the equivalent of direct trauma. But then you have other people who are affected too. So perhaps you're in that room with that person and you're sharing that air. And so you're also breathing that in. Or maybe that person comes to your office and the toxins are in their clothes and like that third hand smoke. These are the kind of what we're getting at when we're talking about vicarious trauma. Sometimes that analogy helps folks.
No, I love that. The secondhand smoke idea really brings this notion into a concrete experience. And, I think vicarious trauma is one of the reasons, as an IO psychologist, looking at my clinical colleagues, I'm like, I could never do that. I do not have the emotional capacity to take on other people's experiences in that way. And realizing now that, I think that would be just very sensitive to the experience of vicarious trauma, especially ever since having kids. I've become a big old softie and very sensitive to
I feel that.
yeah, other people's traumatic experiences. And so this sounds like certainly intuitive experience. I think we can all relate to, if not having experienced it, at least understanding that we don't want to experience it. But from a scientific perspective, that has to make it difficult to capture. And I know that this is an area that you've been doing some work in. How do we measure vicarious trauma?
That's such a good question. And I know you said you didn't want to get into the theoretical weeds on the podcast, but I think we kind of have to just a little bit to get at that.
All right, I'll come with you.
Okay, so when we're thinking about both trauma in general or vicarious trauma, we first have to think that there's an exposure, right? Somehow you've come in contact with somebody else's trauma. And then there is maybe some kind of appraisal process, and it can then potentially affect you if you see this as some type of threat. And that's when you develop the symptoms. And so we actually, for the past 25 years or so, have had a variety of different instruments to measure vicarious trauma symptoms, which could be, for example, having difficulty sleeping, feeling jumpy, rumination, symptoms that actually are really closely related to trauma symptoms and what you might see it with PTSD. And high levels of vicarious trauma symptoms can rise to that clinical threshold. But we haven't had a way to measure systematically where vicarious trauma comes from in the work environment, those exposures. And from my perspective, somebody that works in the occupational health side of things, Well, if we don't know where something's coming from, it makes it really hard to prevent it. It makes it really hard to think about what parts of the work environment we want to fundamentally change so that our workers who are working with trauma survivors don't become traumatized themselves. And so that's where the new instrument that I've developed, the Vicarious Occupational Trauma Exposure Index, it's called the Index, where I think this can be really helpful now for figuring out where those exposures are in the workplace so we can start to think about these organizational interventions to protect our workforce.
I love that so much because I think when it comes to something like trauma exposure, there's the gut instinct of focusing on the symptomology, right? That's how we, in some ways define that, or at the very least, like are tuned into it. But it sounds like the vote here is shifting attention to not necessarily just the outcomes, but rather like what are the exposures in the first place and what about the workplace could potentially be altered? Is that one of the goals of the vote is like you do a workplace assessment and then we can maybe change some things or give you more resources to cope with these exposures? How do you go about using it?
That's a great question. So, to describe the vote index a little bit more, and we could probably provide a link to it for folks as well.
Absolutely.
It's comprised of 16 different questions, which are common workplace exposures to vicarious trauma. Now, we've tested this with the substance use disorder workforce, but it was developed looking across a variety of different helping professional workforces. So, my hope is, and I'm in the process of validating it with other workforces, but my hope is it captures it across different work settings. And so, for each of these exposures, we ask how often it happens to them, and then how distressing it is. So we can try to get at this magnitude, the strength of the exposure as well. And so when somebody takes the vote index, it allows us to see kind of specific like hotspots of exposure. What parts of their jobs are particularly high exposure areas? So is it because they're constantly doing intakes and so they're constantly hearing people's trauma exposure stories? Or maybe it's actually their supervisors and they're often hearing it from their coworkers or the people they supervise, which in some of my preliminary research is actually quite high exposure as well. And so we can kind of identify these hotspots and start having conversations about what can we redesign that work? Can we redistribute it or share some of that work? Or if that's not possible, what can additional supports can we add that's supported at the organizational level to support somebody who's experiencing that exposure so they themselves don't become traumatized. So shifting the conversation from treating the symptoms of vicarious trauma to fundamentally thinking about how can we prevent those symptoms in the first place. So I think that's how it can be used within organizations. But I think the exposures are going to vary by certain types of workers and their jobs and their settings. And so it can also be useful to look at a summary score of their exposure to figure out what types of workers or jobs need to have kind of more of a holistic approach and figure out how to better support those workers. And not to get into the statistical weeds around it as well, but I think it could be really useful as an evaluation tool. So if we have an organization that wants to develop a vicarious trauma intervention, well, that organization is probably more likely to develop it, right? Because they know it's a problem for them. They have higher levels. And so that differential level, if you're trying to figure out how effective something is across organizations, controlling for that different exposure is important for us to figure out what works and what doesn't work as well.
This is just so exciting to me because I think, on the one hand, it sounds like the vote is really treating vicarious trauma like any other workplace hazard, something like chemical exposure or heat exposure, which is, I think, really important and really exciting, particularly in the US where we don't really do that with any psychosocial hazards. I know like we've talked about policy in Australia, for example, that is shifting towards treating psychosocial hazards.
Oh, they're light years ahead of us.
Yeah, light years. And so at least, having this tool to help organizations quantify that exposure to something that they might not be used to quantifying or even thinking about seems really important. But then I love that you also highlight the value of self-reflection here of like, what is my personal potential exposure and what do I need to do to protect myself, in the case that my work isn't, right? And I just think that there's so much to be done there from a very practical perspective and so much utility for both organizations and ultimately workers. I know we like stepped back from symptoms of vicarious trauma to talk about the vote and like what exactly it is and what vicarious trauma looks like or what the exposures are. But What do you know from your research about symptoms? Like what why do I care about being exposed to this other than it feels bad?
Oh, great question. So, as I said, we have had ways to measure symptoms for about a quarter of a century at this point. It's been, as you said, it might be a little bit new to the occupational psychology or health space, but particularly social workers and psychologists who are practicing have been talking about this now for a while. And so, some of our research, and I want to, caution that a lot of it is cross sectional because we often don't fund this type of research. It's hard to do longitudinal studies. But the research has shown that this affects our mental health, high rates of anxiety, depression, PTSD in these workforces. But also, there's really key organizational outcomes that matter as well. So it's been associated with low job satisfaction, with intention to leave jobs and turnover. These are all things that really matter for organizations. There's a large cost behind them. And it affects also our ability to provide adequate care because we're losing the workforce and creating shortages as well. So that's kind of some of the established research. As somebody in the public health space, I've been really interested in it's like, well, there's this, long growing body of research connecting firsthand trauma with not just mental health outcomes, but physical health. And so I've been really interested to trying to figure out if there's kind of these same secondhand smoke, same health effects for physical health too. And that's been a very undeveloped area of research in the vicarious trauma space that I've been trying to tap away at. So one paper that I recently studied, which is the first paper to prospectively look at the relationship between vicarious trauma symptoms and physical health outcomes, found that among workers, I was looking specifically at common gastrointestinal disorders among nurses, and the likelihood of having one of these common GI disorders, the odds of it increased 400% in over the course of 1 year among people who don't have a history of these disorders at all when you compare nurses with high levels of vicarious trauma to those with low levels. My breath was taken away when I saw that. Though intuitively, thinking about my own GI responses as a social worker and what I've seen with managing teams of community health workers and domestic violence advocates as a practitioner, like I'm not entirely surprised. That's kind of what motivated this line of research. But it's really important, I think, for us to demonstrate not that mental health or physical health is any more important than the other, but that it affects our whole body and it's a full body response to what's going on when we're exposed to other people's trauma.
Excuse me while I pick my jaw up off the floor from that 400% number.
I
For
know,
real.
right? So I'm going to say also, it was a wide confidence interval, but highly statistically significant. So
I get it. I'm a sensitive belly boy. I understand. This makes sense to me.
yes, right? It's early days now in this other study, but we're also seeing a significant relationship with unintentional injury. So not something that's caused directly from patient violence, but based upon how we're holding our bodies, muscle tension, distraction, that can also lead to the injury of our workforce through vicarious trauma. So stay tuned on that research, but it's nearing the final stages.
We'll have to have you back for your third appearance.
I'll become a
Um,
regular. I'd love that.
Yes, yeah. What else can we do to help people who are experiencing vicarious trauma? I mean, you've listed a lot of different interventions, whether that's redesigning the work or providing more resources or being aware yourself. But what other interventions might be on the table? Whether this is you're taking from the literature on primary trauma and applying here, or just sort of like spitballing, or you have data. What do we do?
Yeah, well, I think if you look at a lot of the vicarious trauma literature, one thing that I personally struggle with is the emphasis on self care. And we have to operate in order to do self care, whether that's some type of spiritual practice, exercise, attending AA or NA meetings, whatever it is for you, you have to work within systems and organizations that allow for that. And so, one of the things that I hope the vote index does, but also just in conversation, is really shifting the conversation to what do organizations do to allow workers to take care of themselves, that there's a shared onus there. And so you can say, practice mindfulness, and we'll have this meditation course at your organization. But if you're a child protective worker and you're riding around in your car between appointments and eating your sandwich at the stoplight, it's not going to do you a whole lot of good, right? So I think fundamentally we need to be thinking at the organizational level, and that's should not just be an organizational question. I feel like this needs to be a national question because we already have large workforce shortages in these areas. So thinking about, I work a lot in the substance use disorder workforce space, looking at projected nursing shortages with an aging population. We need to be having a national conversation about how we're changing these working conditions because it's going to affect our access to care and our health. And so kind of thinking about those organizational interventions, I mentioned kind of this redesign, things that might seem less efficient for an organization, but on the whole, actually kind of make it more efficient because you're not going to have as much turnover. But there's other things that I think organizations too value, like taking a hard look at the benefits package. So, parity in terms of behavioral health, it's a tricky conversation, but how much are your workers paying for their copays? Well, a lot of our workforce in this era are not high paid workers. Behavioral health technicians, residential assistants, they might not be able to afford their copays. And so I've worked with organizations that mention that they subsidize them. They cover those copays to make sure their staff go to those appointments, especially those therapy appointments, because they're really important to keeping the workers healthy and happy and able to do the work. So another organization, I thought this was a brilliant practice, was now allowing their workers to do teletherapy in the course of the day, private space, don't clock out, so that they essentially get paid during the course of the day to have that baked into their work. So these are kind of more creative things that we can do to build that and make it easier for workers to access the supports if we're not able to fundamentally rework parts of their work environment. And I think efforts like that from an organizational perspective not only increase access, it also goes a long way to decreasing some of the stigma that I think exists around for helping professionals saying that they need help. When I was working in community practice, I remember being told that if I was being impacted by this work, that maybe I wasn't cut out for it. And even if I know that at some level that isn't true, it's hard not to internalize that if somebody that's your supervisor is saying that. And so I think, and I've seen this in some of our qualitative work we do, how deeply internalized it is to feel like you can't ask for help as if you're not strong enough to then do the work. It's fundamentally not true. If we're thinking about this as an exposure issue, as I often think of it kind of equivalent of noise protection, right? Right? It's ambient, it's out there. We have to protect ourselves. And building in these areas that organizations can help workers to access, whether it's therapy or other forms of care for themselves, helps to bring that conversation to the forefront, make it not as invisible, and thereby decreasing the stigma.
You are preaching to the choir. This is music to my ears. I feel seen in my soul. We love a systems level intervention, love the destigmatization of mental health care and like parity between mental health care and, when we think about like physical health. I just love every single one of those. Doing this research, what surprised you the most?
Well, honestly, it was during the data collection process that I experienced all this outpouring of interest to participate in the survey that we were doing to validate the vote index with the substance use disorder workforce. And we were using this quota sampling. Sometimes a portion of the population got kind of tapped out. I had people emailing me saying, I got this. I really want to participate. How can I do that? I had to go back to NIH, the National Institute of Drug Abuse, to say, listen, we allocated this amount of funding for participant incentives. I actually think we need to double the sample size because people want to do this. Can I do this? And of course they let me. That was a great problem to have. But I was just blown away that we more than doubled our sample size that we anticipated. For me, I mean, as I mentioned, I'm a social worker. I came from the practice space. I saw how this seemed to be important to people I worked with. But it was such a good reminder of when research really matters to people. And seeing that come through with the data collection was, I would say, quite humbling. And as a researcher, you have your own questions. You hope it matters. It's really validating when you see that it matters to other people too.
Oh, that's an amazing story. Very like heartwarming in one respect that people are finally getting a chance to talk about this experience of theirs, and that it means a lot to them that they have this opportunity, and then like obviously entirely heartbreaking that they have this experience in the first place. And so I just think it's so cool that you created the space and are doing this research to make sure that those voices are heard, and we love participation in research, so thank you to all those participants.
Oh yes, I'm so grateful. Yes.
But I am going to force you now with my new question for a returning guest, because we've already done our main question for our first time guest. You get the first returning guest question. If you had a magic wand and you could change the workplace for everyone, what is the one change you would make?
Well, probably my employer isn't going to like it, but I was going to say work less and get paid more.
Let's go.
Maybe have daycare thrown in there.
Yeah.
But, I say that in jest, but seriously, we work a lot. And many of the helping professional workforces I work with, especially frontline workers, it's not just that job. And many of them have, on their weekends, are working a second job, often as helping professionals as well. So whether we're thinking about vicarious trauma or other type of psychosocial stressors, or just having any downtime or able to get preventative health care, it's really hard. So fundamentally, I do think that we need to be providing more time off, greater flexibility, and that also has to come with higher pay, which, in the spaces, because you're giving me a platform and a soapbox, I'm going to stand on it, also boils down to reimbursement rates, because in these settings, that's often how people are paid as well. When we don't have high enough reimbursement, especially with Medicaid, well, our workers, frankly, are getting paid just a scratch above the poverty level themselves. That's frankly not okay, I feel like, in our country. So I think in addition to having hard conversations about work environments to keep the workforces that we're so reliant on, we have to really be talking about how we pay them as well from a larger system perspective.
Yes, I never gave much thought to reimbursement rates until my therapist was like, "Hey man, I might have to drop you as a client because your insurance is decreasing my reimbursement rate, and they haven't increased in the last 7 or maybe it was 10 years, and they're going to decrease by 14%." And I was like, "I am so sorry. First of all, I don't mind paying for a service if that money's going to you, but to then just have it to go to a third party or get skimmed off the top, and then the actual people doing the work, the care work, aren't being reimbursed and are being reimbursed less or unfair amounts, just makes the whole system feel terrible."
Mm-hmm.
And so I love that. Stand on that soapbox. I'm right there behind you. It's a great point, and I just appreciate your research and your perspective, and I cannot wait until our next conversation.
Oh, me neither.
All right, bye.
Take care.
Healthy Work is a podcast written and executive produced by Keaton Fletcher and Mariana Arvon. This episode is produced, mixed, and edited by Keaton Fletcher. Artwork is by Keaton Fletcher. And our music is Zero, Microsong by Steve Combs. Please like us, follow us, and subscribe on whatever podcasting software you use. And please leave a review on the iTunes Store. It really does help get us out there.